Good afternoon, everyone. Thank you for joining. We're just going to give it a few more minutes and let folks join, and then we will get started. Good afternoon, everyone. Thank you for joining us today for our monthly QTECH committee meeting. We've got several folks joining as we speak, but want to be respectful of everyone's time and kick this meeting off. Next slide, please. Just want to say welcome, everyone. We are so pleased to see that we have more and more folks joining from our health centers for these monthly meetings. We hope that you are finding them valuable. Today's agenda is going to be very brief with regard to content. So we are going to pass it along. As many of you know, while as of the 2020 UDS manual is not currently available, the PAL was released and some updates have been made. So we wanted to spend a good portion of today's time reviewing those changes. So I'll be passing it off to Harut, and then we will be spending some time diving into cybersecurity with our CISO team. Really appreciate you taking time and then going over some of the webinar highlights that our Chief Clinical Officer, Dr. Tim Long, hopefully you all have been able to join us on those weekly webinars that we've been hosting over the past 9 weeks, really diving in and highlighting the best practices and challenges that our health centers are navigating during these unprecedented times. So with that, again, thank you for everything that you're doing to support our communities and our patients. Thank you for being here today and allowing us to take an hour of your time. And with that, I'm going to go ahead and pass it on to Harut Kasai.
Hey, good afternoon, everyone, and thank you for joining our meeting today. So today we're just going to go over the UDS 2020 changes. This presentation is going to be based on the program assistance letter that was released by the Bureau of Primary Health Care back in February, and also the technical webinar that they held a couple of weeks ago to review the UDS changes for 2020. And additional changes were announced during that technical assistance webinar, so we will be going over those as well. Basically, there's kind of 3 broad categories. There's some major changes that we will look at. There's some clarifications that they've made to existing reports. And then there's we'll just touch on briefly on some of the implications of COVID-19 on the UDS, at least what little they've been able to share with us so far. So if we can go to the next slide. The first table that we see really any major changes is Table 6A. Just as a reminder, Table 6A is the table wherein they collect, this is what I call the bean counting table. So this is a table that collects information on the number of visits wherein certain diagnoses are addressed or certain procedure codes or certain procedures are done, and then the number of unduplicated patients who received these services. So there's the two columns. Column A looks at the number of unduplicated instances where certain diagnoses were addressed or certain procedures were done, and then in column B, it gives the unduplicated number of patients who've received those services over the course of the year. So the first one that they've added has to do with pre-exposure prophylaxis. And again, this is part of this whole ending the HIV epidemic, which is a national priority, and HRSA is one of the lead federal agencies. So the rationale behind trying to really push for this is that, approximately 70%, there's a 70% reduction in contracting HIV from sex when daily PrEP has been used. So again, this is something that's part of this whole push to end the HIV epidemic. So in Table 6A, there's going to be a new data point here for the number of visits where patients were prescribed pre-exposure prophylaxis, and then in column B, we'll look for the unduplicated patients that did receive prescriptions for PrEP. So this is the first major change. Next slide, please. The second change is reporting the number of visits at which selected ICD-10 codes that indicate human trafficking and intimate partner violence. Okay, so, and I think I have them mixed up on the slide here, so please forgive me. So the first one would be for human trafficking. The number of visits at which selected ICD-10 codes for human trafficking have been recorded, and then the number of unique patients who've had one or more visits where human trafficking has been coded. So again, human trafficking and intimate partner violence are serious public health issues and complex social determinants of health that can affect health and quality of life. And it's defined as when a trafficker exploits an adult individual with force, fraud, or coercion to make them perform commercial sex or other work, or when a child is made to work through force, fraud, or coercion. All right, next slide. Okay, so this is the one for intimate partner violence. And again, this is similarly, it's defined as physical violence or sexual violence, stalking, and psychological aggression by a current or former intimate partner. Again, this is something that affects, health in a major way, and so they are collecting this data now. So in column A, it will look at the number of visits at which selected ICD-10 codes that would indicate intimate partner violence has occurred, has been coded in the patient's record, and then column B will show the number of unduplicated patients who've had one or more visits where intimate partner violence has been coded. Okay, next slide. So these next two have to do with the coronavirus. These were not included, obviously, in the PAL that was released in February. This is something that has been added since and was covered during the webinar earlier this month. So two other data points in Table 6A that have now been added. The first one is going to be looking at the number of visits at which selected ICD-10 codes for COVID-19 diagnosis have been coded, and then the number of unique patients who've had one or more visits where COVID-19 has been addressed. Okay. The second one is looking at the number of coronavirus tests. So column A will look at the number of visits at which COVID-19 testing occurred for health center patients, and column B is the number of unique patients who've had one or more visits where testing has occurred. Now, with the testing, I do want you to keep in mind, and we'll, this is addressed in the section where I say we'll look at implications of COVID on UDS. Just remember, for a visit to be counted in the UDS report, it still has to meet the other UDS criteria. In other words, it has to involve independent professional judgment and be performed by a licensed provider and be also entered in the medical record. If you have a visit where the only thing that you've done is a test, a COVID-19 test, and no other services are provided, it would not be counted. Okay, next slide, please. All right, so the next set of changes are changes to Table 6B. These are the clinical quality measures. So the first change is that the clinical measure on the use of appropriate medications for asthma has been removed for 2020. This measure is no longer updated by the measure steward, which is the National Committee for Quality Assurance. It has also been retired from HEDIS and is no longer endorsed by the NQF. So this measure we will no longer be reporting. This is the first major change in 6B. Next slide, please. So the next one is actually a modification of an existing measure. And again, this is also linked to that whole push to ending HIV. This is not an ECQM measure, but it's certainly something that is very important to HRSA and to this whole push of ending HIV. So in the past, what we would look for is patients newly diagnosed with HIV and who had a follow-up within 90 days. This has now been changed. The report is now looking for a follow-up visit to have occurred within 30 days of the diagnosis. So that's the change. Obviously, with this, we just have to note that the denominator dates also change. In order for you to see whether a person has had a follow-up visit within the 30 days and being able to do it within the measurement year, which is the calendar year, the universe of patients would be from patients who are diagnosed between December 1st of the previous year and November 30th of the current year. And then it looks for a follow-up within 30 days. So that 30 days allows you to see a follow-up in December for anybody who was diagnosed in November. In the past, the time period for the denominator used to be October 1st to September 30th. So there's a little shift in the denominator dates also for this measure. Okay, next slide, please. So the next set of measures are newly added to the UDS. Again, following this whole trend of looking at HIV more closely, the first one that was added is the measure for HIV screening. And this is CMS 349 version 2. You'll note that I have put in the hyperlink. If you press on that hyperlink, it will take you straight to the ECQM page that gives you more details on this particular measure. So this measure is looking at all patients aged 15 to 65 as of January 1st of the measurement period and who've had at least one outpatient medical visit. And it's going to look back and see and check if they've had an HIV test done anytime on or after their 15th birthday and before their 66th birthday. So it's basically looking for at least one HIV test done at any time between those ages, 15 and 65. Okay. The second one that has been added is breast cancer screening. This is CMS 125 version 8. And this one is looking for women aged 51 to 73 as of January 1st of the measurement year who've had a medical visit during the measurement period. And it's looking to see if they've had a mammogram done anywhere looking back 27 months prior to the end of the measurement period. So it looks back 27 months to see if they've had a mammogram done. And again, that hyperlink will take you directly to the ECQM page, which will give you more details. Next slide, please. So the last new measure that was added to Table 6B is depression remission at 12 months. This is CMS 159, version 8. So this particular measure is looking for patients who've had a diagnosis of major depression, patients 12 and older who've received a diagnosis of major depression or dysthymia with a PHQ-9 or PHQ-9 modified for teens. So the PHQ-9M and PHQ-9A is the same tool. It's the PHQ-9 modified tool for adolescents. Okay, and if they've scored greater than 9 during the index event, meaning when they were diagnosed with major depression, it looks in 12 months plus or minus 60 days for you to do another PHQ-9 or PHQ-9M and looks at the score and sees if there's been remission. And that would be indicated by a score of 4 or less. So for the denominator, this is going to be looking at diagnoses made between November 1st of 2018 through October 31st of 2019 for the 2020 year. That allows you that 12-month period and then checking to see if the patient had remission. Please note, with this particular measure, the only tool that it's using is the PHQ-9 or the PHQ modified for teens, which is the same as the PHQ-A. This is completely different from the depression screening measure, so I don't want you to get these two confused. For the depression screening measure, you can use any recognized standard tool to see if the patient has, to screen the patient for depression. That's a different measure. So the expectation here is once the patient has a diagnosis of depression, that they would then receive, they would then be administered the PHQ-9 or the PHQ-9 modified for teens to get that score, and then that you would administer it 12 months later to see if the interventions that you have provided have allowed this patient to go into remission. And that would be seen by a PHQ-9, the same tool, or PHQ-9M or PHQ-9A with a score of 4 or less. Okay, so I just want to be very clear that these two are very different measures. This one requires the use of PHQ-9 or PHQ-9A, and the screening one allows you to use any standard screening tool. Okay, next slide. So the other changes, major changes, have been made to Appendix D, which is the Health Information Technology form. This has been revised. The first revision is with respect to the questions that were around promoting interoperability. This program has, as you know, evolved, and there's been some changes, and so the questions in the appendix that pertain to the program have also been revised accordingly. The second change that you'll see, major change that you'll see, is with respect to the questions regarding standardized screening for social determinants of health. In the past, most of the questions were just around, the center's collecting of this data. Now they've added questions, or they will be adding questions to the 2020 UDS that aims to get a better understanding of what centers are doing with this data. And especially, as was mentioned in the webinar, there's a great interest to see specifically around food, housing, finances, and transportation. So they really want to see, what are we doing with this data once we collect it? And so there'll be questions around that. The third change in the Appendix D, the Health Information Technology form, there are some questions to better understand or gather information on centers that are using multiple EHR data systems. So a lot of you have, maybe a different system for your dental, there's a different system for your behavioral health maybe. So there's going to be some more questions to just get a better understanding of centers that are using multiple systems. And finally, they have removed questions on prescription to pharmacy electronically and electronic alerts for reminders. So those questions will be removed from Appendix D. Next slide, please. So now some clarifications that have been made to some other sections of the UDS report. The first clarification is on Table 3B. So this is where they're asking for gender and sexual orientation. In the past, when it was left blank, it was not very clear whether it was just that the patient chose not to disclose or whether the center did not ask those questions. So they are going to be adding 2 new lines. And that is going to be that sexual orientation information was not collected or not asked for, and gender identity was not collected or not asked for. So once the center clicks these, indicating that they did not ask this question, then the assumption for leaving it blank will only be that the patient chose not to disclose. So it will be make it a little clearer as to what a blank means. Whereas in the past, they didn't know whether it was a center that didn't ask or the patient that refused to answer. So that's one clarification. And then they also gave a clarification on, when income information should be collected. And basically, income information should always be collected within 1 year of the last visit. So if a patient comes in this year for the first time, and we look back and see that 1 year has already lapsed since their last visit, then it's time to ask for that information again. Okay, so 1 year is really the standard for when you should be asking for updated income information. Next slide, please. Okay, this is kind of a big one. So this is a Table 6A clarification, which really kind of changes things a little bit. In the past, we'd always said that if you are referring a patient outside for a test, and you, the center, is not paying for that, then that does not get counted in Table 6A. Well, now they've made a clarification. If you are referring a patient somewhere else, even if you did not pay for that test or procedure, if the result is going to be sent back to you and you are the one who's going to be following up on that result, then you should count that in Table 6A, even if you did not pay for it. That's the new guidance. So the determining factor is who is going to be doing the follow-up. So if you're referring somebody somewhere for something that is collected in Table 6A, like a mammogram, and the expectation is if it's a positive, then whoever did that mammogram is going to be doing the follow-up, then you don't count it. But if that result is going to be returned to you and you're the one who has to do the follow-up care for that patient, then you do count it. So that's kind of a big one. As always, relevant ICD and CPT codes, that change will be provided for Table 6A. They always do that, so you'll see the updated ones. As Meredith mentioned, they have not released a manual yet, but we do expect it very shortly. They had said by the end of May, so we'll see. If that happens, we still have a couple more days. Then clarification for Table 6B, and this is on how to determine trimester of entry to prenatal care. So they've made the clarification that the first day of the last menstrual period should be what is used to calculate trimester of entry into care. Okay. Next slide, please. As always, they update the ECQMs. They've updated age ranges to align with the updated clinical quality language. And you'll always see that there's new versions of the ECQMs. Sometimes the changes are very minor, just maybe in the description of the measure, just to make it a little bit more clear. But there are some measures that some changes that we should note. Some are a little bit more impactful than others. The first one is that they've added exclusions relating to patients 66 and over for some measures. And specifically what they're saying is that for some measures, they're allowing to exclude patients 66 and older with advanced illness and frailty because it might not be worth or there may not be any benefit from screening such patients. So for example, for the colorectal cancer screening, they've added this exclusion. So if you have a patient that is 66 and over and has an advanced illness with frailty, then you could exclude them for that measure. And that has been added to a couple of the measures. For depression screening, they've added a little bit of leeway as to when the depression screening can occur. So the depression screening now allows screening to occur on the date of the visit or 14 days or up to 14 days prior to the visit. Okay. And again, the hyperlink will take you directly to the ECQM if you want to read a little bit more on it. The next one is hypertension. And if you recall in the past for the Table 7 report on hypertension, to fall in the denominator for this report, the diagnosis of hypertension had to have been made prior to June 30th of the measurement year. So anybody who was newly diagnosed with hypertension after June 30th of the measurement year would not have been in this denominator. That is no longer. It is looking for any patient that has an active diagnosis at any time during the measurement year. So even if the patient got diagnosed with hypertension in December, it is still going to be included in the denominator and is going to be checking to see if that person's blood pressure is controlled. As far as some added information about remote blood pressure monitoring, I think this is just to reiterate, and I think we mentioned it last time, self-reported blood pressure from patients is not UDS countable. If they have a monitor that automatically feeds information to the EHR, then that's okay. But a reported blood pressure taken by the patient and reported to the center is not allowable for the UDS measure. You should certainly get that information, especially with telehealth. I'm sure it will help with dealing with the patient's disease state and trying to get a handle. But until we can get them in to actually take a blood pressure reading, that reading that the patient tells you cannot be used for UDS purposes. And next slide. So one last clarification, and this is to do with Table 9E, which is one of the finance tables. They've added some guidance on sub-awardee and sub-recipients, and they may include a new line in the Bureau grant section to reflect COVID-19 drawdowns. They did make a point at the webinar to make reference to changes as of April 17th, I believe is the date that they gave. They haven't said anything further, but that kind of gave me the clue that maybe there might be some other things that they would clarify or some things that they would add. Again, that's just my perception. And they haven't released the manual yet, so we will definitely keep an eye out. And if there are any other changes, we will definitely share them with you. And I think that's okay. I think there's one other section. So next slide. So again, some of this I already went over earlier. So, implications of COVID-19 on UDS reporting. we already covered this, where an individual only receives COVID-19 screening, this is not considered a UDS reportable visit. But if you have an individual who receives additional services with their COVID-19 screening, services that required independent judgment from a health center provider, and where the encounter was documented, certainly those are UDS countable. With respect to virtual visits, as you all probably remember, this was added to UDS last year, where we were for the first time permitted to count audio and or video telecommunication that permitted real-time communication between the provider and a patient. What we cannot include in UDS is any asynchronous store and forward type information for the provider to review later on. That is not UDS countable. The provider and the patient have to be able to communicate to each other in real time. Those types of visits are UDS countable. And I think last year we had gone over how those should be coded. So just a reminder, those visits are UDS countable. Okay, and on the next slide, I've given you some of the reference materials. This is hyperlinked. So you can get the link to the program assistant letter that was released in February, the webinar, the PowerPoint from the webinar earlier this month, and then of course the UDS resources webpage, which is always has a lot of information. Okay, and that concludes my presentation. So I don't know if there's any questions.
So we do have a question in the chat from Nurez from True Health, and he is asking for the COVID-19 testing, those changes that you shared. Is it for active virus testing only, or does it also include the antibody test?
So they did not make the distinction. So let me go back to that slide so that I can, because the screening test, and I'll verify this with them, but to me the screening test would be the not the antibody one. I mean that only shows if you've developed antibodies, and it could be afterwards. But I don't want to speak out of place, so we will get back to you with that answer. As far as if it includes the antibody test as well. I don't believe it does, but I would like to check that before I give you a definitive answer. They did list out the code, so we can get a clue from the codes that they list. Actually, they should be listing those in the UDS manual. These were not part of the PAL, so we don't have the codes that they're actually looking at. But we will get verification on this from the UDS help site. Any other questions?
Okay, so we are also, yes.
Hi, I have a few questions. One is regarding the depression screening. Basically, according to what I read in the UDS dashboard, it's stating if depression screening symptoms, or if depression was found, if symptoms were found, the patient must have at least one of the following within 1 day of the screening. So they could have an additional PHQ, okay, or a referral to a provider qualified to diagnose and treat depression, or a follow-up visit for depression, or a prescription for an antidepressant. Now, there's a lot of medicine codes that were related to the reporting on this. And basically what I need to know is, are you going to be developing a best practice workflow to obtain this information? And also, because we do have a separate behavioral health EHR, how would we capture information if a patient were to be treated and seen for depression by a psychiatrist? That's my first question.
You're not. You're referring now to not the new depression screening that's being added. You're talking about the depression screening that's inside. So we are working on updating our forms for the depression screening. And the second part of your question was?
Well, basically, because we utilize a separate EHR for behavioral health, how would we document that the patient has had a follow-up visit for depression if it's not put in Intergy?
So hi, Allison. This is Meredith. So this depression remission measure is very similar for those of you who may be involved in the ACO and are reporting out on that measure. We are currently, our team in general, for those of you who are on Intergy, are walking through and evaluating workflows as well as working with Greenway on what those reporting aspects will be. So there is more under development and more to come. Specifically for those of you that are using a behavioral health EHR, we will need to be getting guidance from HRSA and looking at how that information is reporting out. So we will be taking that. We are also waiting on details in the 2020 UDS manual to see how they may outline the reporting specifics to this measure because it is different, but we will certainly take that as a follow-up and bring that back to this forum, if not sooner.
Yeah, because we went from like 95% to 1%.
Yeah, this measure, the depression remission measure, we have been following in different forms for our Medicare population for several years now. It is an extremely challenging measure because there are multiple components in which you're looking at varying timeframes and follow-up. So I think it'll be a great opportunity for those of you. We will be launching our validation work group in the coming months, and so we will extend that and look at very specific targeted subjects to address that, and this is going to need to be one that we address.
My next question has to do with the HIV follow-up within 30 days. Now, generally, we normally diagnose and treat the very same day. That being said, our numbers in Intergy have always been very low. One, because you never utilize the treatment the same day as diagnosis as a valid visit. And it's still relatively low, although higher. So when we're talking about diagnose and follow-up, I know that the health department and whatnot look for treatment, testing and treatment within the 30 days. So since we start the same day, why isn't it picking it up?
So we would have to look at, I think that problem was resolved for many centers. So if it's still an issue, we would need to take a look at the details of your center and see what's going on.
Yeah. And my last question is I wanted to know if you were going to be adding the D0140 to the dental for emergency visits because it was lacking last year.
I cannot answer that off the top of my head, but I will, if you can just put it in the chat so that we can make sure to follow up on that.
Sure. Okay, that's it for my question.
All right. Okay, any other questions on the 2020 changes to UDS? Okay, so if there's no other questions, I will pass it on. If you have any other questions later on, you know where to reach us. And of course, you have the references here that can help you. Okay, thank you. And I'm going to pass it on to Michael, who will be covering topics on cybersecurity during COVID.
Thank you, Hiro. So it's just I'm Michael Sagili. I handle the cybersecurity for HCN when it comes to the customer side. So I see a lot of different cybersecurity implementations at the health centers. So today I was going to talk about the latest attack which is the Zoom attacks. We've mentioned them before, and we're going to continue mentioning them again because they are just always on the rise. This is still the strongest attack out there, so we just want to keep it at the front of everyone's minds. So let's jump right into the first slide where we can see right away where they set up these fake Zoom websites. This is a fake Zoom website on the left-hand side. As you can see on the top, it says zoom-us-zoom.dl, which is a fake link. And on the right-hand side is what a fake download installer would look like once you download the software that they're trying to get you to download. That installer on the right-hand side is what you're going to see installing this fake Zoom client. So the latest attack, what they're doing is they're trying to send you over to this website. Let's actually jump over to the next slide so I can explain the process. So the latest attack, what they're trying to do is get you over to this website through phishing emails, and they'll try to convince you to download the latest Zoom client or tell you to update your client or tell you your client is not in compliance of some sort, and they send you a link trying to look like their Zoom and to get you to download this new Zoom client. Now, the dangers of this attack is that you actually are downloading the real Zoom client. What they do is they go to the actual Zoom website, they download the real Zoom client, put that onto their fake website, have you download that Zoom client, but on the background of that Zoom client, they actually attach a malicious software called a RAT for short, which stands for Remote Administration Tool. And as you install that Zoom client from their website, which is actually legitimate and you will be able to use it in everything, at the same time, they plant that RAT into your computer. Now, what that RAT can do on your computer is it can do everything from download your files. It installs a keylogger, which essentially will save every keystroke you type onto your keyboard, so they'll be able to access your passwords and see whatever password you type in. They can even go as far as accessing your webcam, anything. They basically have full control over your computer. And the purpose of that is to exfiltrate data out of your computer. So if they're targeting the health centers with this, because they know a lot of health centers are using Zoom Healthcare, Zoom clients for meetings, they will try to see if they can access patient data from your computer and try to exfiltrate it. Or if they spread this RAT around large enough, they take all the computers that are infected, and then they will use all the power from those different computers to target a different organization or some sort of server, and they will use those computers to attack that one specific area at the same time. So we wanted to bring that up today because we still see a lot of people clicking on these links. A lot of people have been infected by this remote administration tool through this email that's sent, convincing them to download the latest Zoom client. So we wanted you to be aware. And in that last example you saw, that was actually not the best example of a website. Some of these are more sophisticated and look just like the website. So a few tips to know if it's a fake website is you look at that link at the top that we saw. You could go back to the previous slide. We're not there yet. If you look at that link at the top that we had saw, you saw that the website said zoom-us-zoom.dl. Zoom is always zoom.us or zoom.com. If you actually type in zoom.com, it'll redirect you right back to zoom.us. So it's fine. But just anything that looks fishy, just pay attention to the link and make sure it looks legitimate and doesn't look anything out of the ordinary. And the email, you start that off at the email. If you see that email come in and the domain that it's coming from, the email address that it's coming from is not a support@zoom.us, and it's something strange, at gmail.com maybe, then it can potentially be malicious. And your best bet, the best tip I can give to anybody here is don't even click the link. Even if you're unsure or you're positive, you don't have to click the link. Go directly to the Zoom website, close out that email, open up your browser, go to zoom.us and download the client directly from the Zoom website. You can use that same tip for almost any phishing email that you're not sure of, something that they're getting you to download or something that they want you to open. Go directly to the website yourself on your own browser and try to access it. Or if they want you to download something from some coworker and you're not sure, email that coworker directly or reach out to them directly and ask them, is this legitimate? So we just wanted everyone to be aware of that latest attack. We've been seeing it on the rise again. So just to give you an idea of what it looks like. Now, next slide, please. So let's talk about staying HIPAA compliant from home. Another issue we've been running into a lot is the Hipaa compliance from home. It's a new thing for all of us. We're working on our laptops at home. We have kids on the other computer, so sometimes we switch computers and then we access different files of different computers. And before you know it, you've moved one file over to another file, or you logged in somewhere and left it open on one computer in your living room with patient data on the screen, which is a HIPAA violation. And it's just something to be aware of. So just a few items that we wanted to list. Never download ePHI. We've seen instances where somebody wanted to move from one computer in their house over to another, and maybe they were accessing some PHI or some sort of data. They decide to just download it really quick into a USB drive and move it over to a laptop or some other way. Now the problem with that is now you're exposing that USB drive out in your area. If somebody takes it or moves it around and loses it, you have potential PHI on there that can be exposed. So just never download ePHI unless there's a very good reason, unless you've spoken to your IT department and they make sure they give you some sort of encrypted hard drive that you're going to place it on so that it can't be accessed. If somebody finds it, they can't take the data that's off of it. So just be safe and never download ePHI. The next one is make sure you are on a secure connection while accessing your EHR. A lot of us access electronic health records throughout the day and we use different softwares. Now, a lot of things are opening back up. So we've heard of people going over to Starbucks to work from Starbucks or McDonald's or whatever it may be. Public Wi-Fi is never a secure connection. You should always be wary of accessing anything through public Wi-Fi unless you have something like a VPN, which stands for Virtual Private Network. Essentially, it secures every piece of data coming out of your computer. We'll put it in like a tunnel of sort and will be secured from anybody. Even then, you still don't want to access your EHR over a unsecure web Wi-Fi system, just like in McDonald's or Starbucks or anywhere that's public and widely available. Hackers can sit in that same restaurant that you're sitting at or that same Starbucks or McDonald's and can eavesdrop on all your data that you're passing over that Wi-Fi connection. They can also spoof that Wi-Fi connection and use their own device to broadcast a connection that says a Wi-Fi name that says Starbucks or McDonald's, and you're thinking you're connecting to Starbucks or McDonald's, but really you're connecting to that hacker's laptop or device that he has there. And now he's able to intercept everything that you're sending out as he acts like the middleman between you and the internet. So just always make sure you're on a secure connection while accessing your EHR. Use a VPN if you can, or make sure you're logging into something like Citrix that we provide at Health Choice Network. That is a secure environment. You log into Citrix, doesn't matter where you are, as long as you're logged into that environment, you're in a secure environment that's accessed in servers elsewhere that is hosted by us, and we have different security features in place. So the next one is a very simple one, verify that all systems are up to date. This has to go with staying HIPAA compliant, because if you have old systems that have never been updated, your Windows still is Windows 7 and you haven't pressed that update button in years. A lot of us like to just click, ignore, we'll do it later, and we never get around to doing it. That is actually a violation with the HIPAA security rule, because that old Windows 7 system that we haven't pressed update on in a very long time has vulnerabilities in it. These vulnerabilities are taken by hackers, and then they're able to breach your systems through this, and then essentially possibly compromise patient data. This next one and last one here is more for leaders of your organization or HR. Create a remote work policy document. A lot of us, we were just thrown right into this and had to work from home from one day to another. And it was a very difficult transition. Now that we've gotten more accustomed to it, we've learned new things every day. So now is the time to create a remote work policy document. As we've learned so many new things since this pandemic has become, there's a large amount of resources online now that gives you sort of templates to creating a remote work policy document. And it's just great to have in your organization so that everybody can be aware. In that document, you would place a lot of this information about being HIPAA compliant from home inside of that document, so that everybody can always refer back to it in case they're unsure of something that they may be doing from home. So now telehealth, we've heard this one a couple times, using end-to-end encrypted video conference solution. What end-to-end encrypted video conference essentially is if I am doing a video conference with a patient, my desktop or laptop directly to that patient's phone, desktop, or laptop is completely encrypted, which will not allow any attackers to eavesdrop or steal any data. Even if somehow data was compromised, but it is encrypted, they would not be able to access it. Only you and the person you are connected to have the decryption keys to actually view that information. So a keyword to see when you're out there looking for a video conference solution for your organization is look for the words end-to-end encryption. Zoom actually has gotten in trouble in the news lately because they spoke about having end-to-end encryption, but they didn't have true end-to-end encryption. So they sort of fell under several issues with the public because of this. And then they created something called Zoom for Healthcare to try and resolve some of these issues. Hipaa has recently, or the OCR really has recently lifted some of the sanctions of having to use end-to-end encryption devices. And they've listed certain things like FaceTime, WhatsApp video, I think Facebook Messenger video that can be used to see patients in order for providers to be able to see patients in any way they can at that moment, seeing as this kind of just came up out of nowhere for us. So for those of you though that want to stay a little more protected and have some privacy protection measures in place, there's Hipaa compliant vendors for video solutions, for video conferencing solutions, or telehealth solutions in general. Microsoft Teams is one, UpDocs, Doxy.me, Zoom for Healthcare, and Cisco WebEx. They all have Hipaa compliant solutions that provide you a BAA for both parties to be able to sign, so that it kind of adds you another layer of protection, legal protection as well. So those are some of the solutions to look at overall to stay Hipaa compliant and be safe from working from home. That's really all I wanted to mention today, sort of hit the big topics today. So if anybody has any questions for me, feel free to ask. I think we're good to go.
I do not see any questions in the chat at this time. So thank you so much, Michael.
Thank you, guys.
Great. So today I'm going to speak to you about the COVID-19 webinar series. As we mentioned earlier, we have been hosting a weekly session to gather all the different health centers across both networks from Alliance Chicago and HCN as well, Health Choice Network, to share their stories as they've gone through the COVID-19 experience during this public health emergency. So today what we would like to cover is an overview of Session 8. So Session 8 was primarily focused on the patient experience. So being able to hear what that transition from normal care in terms of insight at the health center to now going virtual for telehealth, how that experience has transpired and what are some lessons learned that we can kind of gather and bring forth with us as we go beyond COVID and implement virtual care as part of the processes we have today. So some of the highlights to share from session number 8 include we actually had from Crossing Healthcare, which is an Alliance Health Center, we were able to have a provider join, a pediatrician who was able to link in a patient of hers, the mother of a patient of hers. So it was a very interesting perspective to get that experience of how a mother who had to transition into telehealth for her daughter and how that care was established. So it was a very interesting story to hear from her perspective on how the transition to virtual care has been pretty much seamless on her end. And she still feels very much connected to the health center, but she made some great points from her perspective as a patient. She was sharing, I'm not sure how things will go back to normal. I can't imagine waiting in waiting rooms. So there was really great experience and feedback that from her patient experience that was shared during session number 8. We also had the opportunity to hear from other patient experiences, one of which being from Near North Health Service Corporation. We had an HIV program manager who spoke about that transition to telehealth and what that experience has been for their patients. Some other key things to share include the follow-up component as well. So we actually had some insight from Miami Beach Community Health Centers on what that positive patient management experience is like and how you go from testing patients, whether it's external or internal health center patients, in terms of the positivity, what's the protocol to follow from their perspective, knowing their experience and what's been out there. We also heard from Empower You, which was great as well. They shared their experience of how they were actually in a moment of transition where they were the site of care for virtual STI test and treat program through the local Department of Health. So they experienced that transition in their operations during COVID-19. So it was interesting to hear about their perspective. There were some other key items shared during session 8 about how some of our health centers have actually tried to figure out how to improve the patient experience. So whether it's creating documentation that can help patients understand how to access those video conference or telehealth technologies, how to go through the process of testing, having clinical staff walk patients through that process of testing, whether it's Zoom or I Am Your Doctor was another one mentioned, making sure that they're able to access the technology successfully and in a way that enables a video whenever possible so that they can get the most out of the experience for their virtual visit. So those are some really key experience to learn from in terms of session 8 for patient experience. I'm going to go ahead and just go to the next slide here. So here we're just thanking all of our representatives. We've had a variety of health centers who've been able to share their story across the nation, as well as some national partners who've provided some education for us as well in regards to COVID-19. So this is just a shout out to say thank you to all of those that have presented and shared the great information and insight from that presentation. With that being said, we actually have all the recordings available. So you can actually go ahead and click on these different links here, and you'll be able to hear about the insights and different topics that we've covered so far in our COVID-19 webinar series. In terms of COVID-19 resources, we're just going to make a plug here for our resource library that we've had accessible. There's many different folders available for the team to access information in regards to COVID-19. We primarily update these with a lot of information that should help provide insight to some of the topics we covered today, whether it's cybersecurity or even with this COVID-19 webinar series and lessons learned and best practices that we can gather, hearing out other health centers' experience during this process. This slide really is just an opportunity to share some of the resources that National Association of Community Health Centers has provided during COVID-19. So that's there for your information. So lastly, before we wrap up, our next meeting is set for June 25th of 2020. And we are excited to announce that we'll actually have HITECH join us during that session. So it'll be a great time to hear from one of our national technical assistance partners to share some insight and opportunities on patient engagement, telehealth workflow, or even provider burden elements. So more to come on that. And I'll pass it to Meredith in case we have any other closing remarks.
Thank you so much, Stephanie and team. Thank you very much. Want to thank you all for joining us today. If I can just draw your attention, I want to make sure we highlight just in the past, many of you, we have tried to make sure that we're providing an opportunity for our health centers to connect with each other. So just want to draw your attention to the QTECH reps document under handouts. These are our lead contacts at each of our health centers. We encourage you all to reach out to each other as you're navigating various different topics. And as Stephanie mentioned, we are very excited to be bringing some more detailed discussion. We've highlighted several key areas, especially regarding coronavirus. We really want to take an opportunity to dive into and further the discussion on patient engagement. And would love to hear if any of you are interested in presenting in future meetings or have topics or innovative items that you have been working on. We'd also love to hear from you as well. So With that, we will give you back the rest of the day. Thank you for all that you do. I'm so very honored to be able to work with this group. And we are here at HCN to support you. So with that, I hope you enjoy the rest of your day, and thank you very much. Take care.